Welcome to Case of the Day. This is the last case of this week. We have the 43rd case, which is titled Post-tuberculosis Bronchomalacia. So this 41-year-old with asthma has cough that increases at night with breathlessness on exertion. Treated for TB in 18, had 2 scans in 17-19, but the paper report mentions left main bronchus involvement and an opacity in the left lower lobe. So the CT we did yesterday and I read today shows these fibrocalcific areas, left main bronchus narrowing, post-obstructive atelectasis of the anteromedial basal segment, and some peribronchial thickening, tubular bronchiectasis, mucoid impaction, etc. But the MINIPs in the inspiratory phase show that there is about 50% stenosis of the left main bronchus, about 2 centimeters from the origin. But it's the expiratory images that take the cake. And you see here both in the coronal and the axial plane that the stenosis becomes greater than 90%. And this basically therefore is a form of bronchomalacia. Now these are 4 millimeter MINIPs that show this stenosis between inspiration and expiration well. The only thing is, despite the extent of expiration, we don't see additional significant post-obstructive increased lucency. So the overall volume of the left lung is less. There are patchy areas of air trapping in the left lower lobe and in the lingula as well, but nothing dramatic. Now, TB involvement of the tracheobronchial tree is not uncommon, including post-TB stenosis. And so here is a patient, 16-year-old, classic TB findings of infectious bronchiolitis, cavitation, has this long segment left main bronchus narrowing, including the superior division here. And I did this case at ctchestreview.com where you see marked stenosis as a post-TB sequelae of a patient who had TB. And these do keep coming up at times, but it is not common to see this kind of change during expiration. Bronchomalacia itself. This was a lovely radiographics paper that was written up from Prachi Agarwal's department. And what it did was it kind of gave us an umbrella term and explained it. It's expiratory central airway collapse, which has two typical patterns. Tracheobronchomalacia, where both walls collapse, and EDAC, or excessive dynamic airway collapse, where the anterior wall typically remains convex. Now these are the various causes on the right that I've copied from that article. But you see that while repeated infections is here, TB doesn't get a mention. And there are a couple of papers on post-TB bronchomalacia, but they are more related to bronchoscopy and treatment options, etc. How significant is this? Looks so dramatic on the CT, but the referring physician is not sure this correlates with the patient's symptoms. If it did, then there are treatment options such as stents, bronchoplasty, etc. So just to summarize, TB can affect the tracheobronchial tree. Tracheobronchostenosis is a form of post-tuberculous lung disease, or PTLD, though it doesn't get a mention in that chart that I'd put up when I did PTLD. I think it was the 3rd or the 4th case when I started Case of the Day. Tracheobronchomalacia diagnosed from inspiratory scans in PTLD settings is not common. Maybe we're missing it because we don't routinely, or many people don't routinely do expiratory scans. We do. And I think it's one more reason to include routine expiratory scanning for all patients. That's the Leadership Summit, my WhatsApp channel. And thank you for viewing this. I'll see you next week.